Periodontitis is not just one bacteria. It's a biofilm fortress. And if you want to break this fortress, we need to deliver something that will attack inside the pocket. Welcome to Regeneration Hub Pune. In today's YouTube video, we are going to simplify a topic known as local drug delivery or LDD. When to use, why to use it, indications, comparison with systemic antibiotics, and finally we'll see a case of periodontitis being treated using a local drug delivery system of tetracycline fiber. So let's start. Periodontitis is a complex biofilm-mediated infection affecting tooth supporting structures. It's characterized by progressive pocket formation and attachment loss. The microorganisms responsible for these are majorly gram-negative anaerobic bacteria, which adhere strongly to the root surface and also to the adjoining periodontal sulcus, and some bacteria they invade the adjacent gingival tissues. Now, the effective elimination of pathologic biofilms, it represents the cornerstone strategy in contemporary periodontal therapy protocols. There are non-surgical and surgical management of periodontitis. The basic treatment, that is phase 1 therapy, includes treatment modalities like scaling and root planing, which is the core mechanical therapy for any biofilm disruption. Also, other modalities like antimicrobial therapy, which includes systemic antibiotics and local drug delivery use, or chemical plaque control, where we use mouth rinses and some irrigations, post modulation therapies, more adjuncts like laser therapy and photodynamic therapy. Amongst these, scaling and root planing is considered to be the gold standard. It is the cornerstone of phase 1 or initial periodontal therapy. It basically causes mechanical disruption of this plaque or biofilm, has root surface detoxification. It eliminates the endotoxins and pathogenic microorganisms and restores the tissue health for further treatment. However, there are certain limitations of this scaling and root planing. First is due to anatomical barriers like deep and narrow periodontal pockets. They restrict the instrument access. Then there are certain complex root anatomy, like in case of furcation involvement, which creates inaccessible zones where mechanical instrumentation cannot effectively reach the biofilm. Then there are tissue invading pathogens, especially gram-negative anaerobic bacteria, penetrating gingival epithelium and connective tissue beyond the reach of mechanical therapy. And there are persistent bacterial reservoirs as well that contribute to disease recurrence and treatment resistance in susceptible sites. So, turning over to the use of antimicrobial therapy as an adjunct, where two main systems are used, that is systemic antimicrobials and local drug delivery. Systemic antimicrobial consists majorly of oral antibiotics that are administered for systemic distribution through the body, reaching periodontal tissues via circulatory pathway, and they are typically reserved for periodontitis, but more specifically for aggressive or refractory periodontitis cases. Local drug delivery, where controlled release antimicrobial agents are placed directly into the periodontal pocket and achieving high local concentration while minimizing systemic exposure. Now, there are certain clinical limitations of systemic antimicrobial therapy, like they have limited periodontal penetration because of poor diffusion into the periodontal pocket. There is need for dosing requirement. So achievement of therapeutic levels necessitates higher and more frequent dosing regimens, increasing the patient burden and cost. As at the same time, there are some gastrointestinal complications associated with the use of antibiotics. Then there is antimicrobial resistance and patient compliance challenges. To counter this, local drug delivery therapy is advised. It basically involves direct placement of antimicrobial agents into periodontal pockets using controlled release vehicles. The advantages being high local concentration at the target site, minimal systemic exposure, sustained release, and site-specific action, since it targets localized disease without affecting non-diseased areas. The indications for local drug delivery are first maintenance patient who are on supportive periodontal therapy and with persistent inflammation, then certain medical contraindications for surgical therapy, including cardiovascular, bleeding disorders, or immunocompromised patients. Then institutional care settings where patient efficient periodontal management becomes difficult. Localized treatment resistance, where sites demonstrating persistent disease despite conventional mechanical therapy and adequate maintenance. Then there can be implant complications like peri-implant mucositis, or pre-operatively or pre-regenerative surgery, one can use local drug delivery. There are different types of local drug delivery systems or LDDs. You can classify them in various forms. One form is in the form of fibers, strips, films, microparticles, and gels. It can be available in all these forms, or you can classify them based on release characteristics like sustained or controlled release or fast release. Also, based on biodegradability, they can be classified into non-resorbable and resorbable ones. These are the major classical studies on the use of local drug delivery. It all started with a landmark study by Goodson, who postulated the local application of tetracycline directly into periodontal pockets. Then 83 again Goodson tested the use of monolithic fibers containing tetracycline in clinical applications. This work led to the development of the first commercial LDD product, that is Acticide, marking it a major milestone. Then Hardy in 82 delivered chlorhexidine solution into the periodontal pocket. Higashi and Nakagawa developed and assist other products like ofloxacin system and 2% minocycline ointment. Coming to the use of fibers, they are basically reservoir type of drug delivery systems designed for placement around the circumference of the periodontal pocket using an applicator and maintained in situ by a adhesive or a periodontal dressing. There are various types of fibers used. They can be synthetic, like polyurethane, polypropylene, cellulose, propionate, or acetates, or they can be in the form of natural fibers like chitosan and gelatin. One of the most commonly used antibiotic is tetracycline. It's a bacteriostatic antibiotic that interferes with bacterial protein synthesis and also inhibits tissue collagenase activity. It has a broad spectrum activity, inhibiting both gram-positive and negative organisms, including the beta-lactamase producing stains that occur in approximately 50% of 6 to 7 millimeter deep periodontal pockets, and against which normally the penicillin alone is ineffective. In the treatment of periodontal disease, tetracycline and its derivatives have been used systemically as well as locally. One of the product that is available in India is Periodontal Plus AB. It's a bioresorbable tetracycline fiber based on a collagen film system composed of 25 milligrams of pure fibrillar collagen uniformly saturated with approximately 2 milligrams of tetracycline hydrochloride. The fibers are arranged in a strip comprising 4 separate sterile product packs, each individually packaged and detachable, and the fiber biodegrades in the periodontal pocket within 7 days. There are variety of studies on Periodontal Plus AB. One is local treatment with Periodontal Plus AB showed significant gain in clinical attachment loss and reduction in probing depths compared to the control group by Khan in 2014, also by China in 2015. One study by Gill in 2011 showed the intercomparison of clinical efficacy between tetracycline fibers and a xanthan-based chlorhexidine gel, that is Chlorcyte, showed that tetracycline fibers were better, that is, they had significant gain in clinical attachment loss and reduction in probing depths than chlorhexidine gel. So let's see a case of periodontitis treated using local drug delivery system of Periodontal Plus AB.
Here is a case of generalized periodontitis. We can notice the maxillary anteriors. There is diastema, pathologic migration. There are mandibular anterior missing teeth. There are deeper pockets, generalized deep pockets. Once the probing examination is done, we can notice the probing depths somewhere around 4 to 5 millimeters around second quadrant areas, that is 2.1, 2.2 and 2.3. This is on the palatal side. We are taking the measurements of the probing or the pocket depths. First central incisor, then 2.2 at 6-point marking or 6-point pocket charting. We do it in a standard way. We also notice that the oral hygiene index and the periodontal probing depths, this is before the scaling process and this is after the scaling. In the periodontal chart, one can notice the deeper probing depths, and after the scaling is done, this is the re-evaluation phase, the remaining pocket depths. The preparatory plan is to deliver the non-surgical treatment in the form of local drug delivery using Periodontal Plus AB. It comes in this kind of packaging, 4 vials individually packed. So one vial is being used here. The required amount and quantity of the tetracycline fiber can be taken out and kept ready for the delivery into the periodontal pockets. One can use tissue forceps along with some kind of a blunt instrument so that it doesn't hurt the gingival areas. So this is the tetracycline fiber that is first being arranged circumferentially around the gingival margin, and using a blunt instrument like cord packer or any other blunt instrument, it can be packed circumferentially around the pocket areas. So this is around 2.1 that tetracycline fiber is being inserted. Once that is done, care must be taken not to traumatize the gingival areas. So here it is almost packed completely inside the pocket area. Now the fiber is being placed onto the palatal side of 2.1. Now 2.2 and 2.3 as well on the labial as well as the palatal side, using the same cord packer to insert the tetracycline fiber. This treatment is used as an adjunct to scaling and root pinning. The phase 1 therapy is already been done in the previous appointment, and now after adequate root planing, this is the treatment of delivery of local drug delivery is being carried out into the periodontal pocket. As discussed in the theory, it is not recommended to be used as monotherapy but as an adjunct to scaling and root planing. So around canine also the fiber is being packed. And once it is done, we are going to cover it up using a periodontal dressing on both buccal as well as palatal aspects.
So what is the final take-home message for LDDs or local drug delivery? They show potential for targeting periodontal infections with high drug concentrations while minimizing systemic side effects. They do not provide a superior result when compared to scaling and root planing. That means they cannot be used as a monotherapy. However, they can definitely be used as an adjunct to phase 1 therapy or as an adjunct to scaling and root planing. The adjunct use of local drug delivery may improve the results in sites that do not respond to conventional therapy. Also, maintenance patients with a few residual pockets may also benefit most from the use of local drug delivery. Thank you for watching this video, and for any of the upcoming workshops on hard and soft tissue augmentation around teeth and implant, root coverage workshops, or immediate implant workshops, feel free to contact on the numbers that are given. You can also log into our Instagram channel and check variety of clinical cases related to hard and soft tissue augmentation. Hope to see you soon in the next video. Take care. Bye bye.